Hello, everyone. Welcome to another episode of Doctors Go Live. I am your host, Nina Cheryl Khan. And for Doctors Go Live today, we are talking about colon cancer screening and what are our options. Okay, so let us know who's tuning in right now. I can see Mary, Hannah, Joe, Shabet. Thank you for joining us every single week. Where are you tuning in from? And what would you love to know in today's episode of colon cancer screening? What are my options? Now, if you share this video out, you get to take part in our Doctors Go Live quiz happening right here at the end of the Q&A, where you get to win some amazing prize. And today it is drawstring bags, okay? And all this is happening right here in Doctors Go Live with me, Nina. And our special guest for today is Consultant General Surgeon for Columbia Asia Hospital, Bintulu, Dr. Ahmad Khairil Irham Harun. Now, so one of the most common types of cancer, which usually does not cause any symptoms until the disease is well advanced, is colon cancer. So, with diseases such as this, getting regular screenings very early is an integral part to preventing this disease. But what are our options when it comes to screening? What are the pros and cons of each screening, and how often should we be tested? Knowing all this can help us take the necessary actions quickly and maybe even save our lives or our loved ones. So today we're looking into all this and more happening right here on Doctors Go Live. Now, if you know anyone who's going to find this information useful, or if you think this is such an important topic and subject and you want to make a difference to people out there, then please share this video out. Tag all your friends. Follow us on our social media because this episode is definitely going to make a difference. Hello, everyone. Sanya, Tan Q Shing, Kamala, welcome, and Oko as well. All right. So if you've just tuned in, welcome to another episode of Doctors Go Live, where today we're going to be talking about what are our options when it comes to colon cancer screening. Colon cancer is one of the most common cancer diagnosed. So here to help shed some light on what options there are when it comes to colon cancer screening, please welcome Consultant General Surgeon from Columbia Asia Hospital, Bintulu, Dr. Ahmad Khairil Irham Harun. Okay, Doctor, welcome, Dr. Khairil.
Yeah,
Thank
hi
you so much.
Nina. Yeah, I'm glad to be
Okay,
here to join you
okay,
all in this afternoon.
thank you. Okay, so before we begin, yeah, Doc, I just want to remind our audience and viewers that please pay attention to you because he's going to be providing some answers to the quiz questions happening right at the end, where you get to have some drawstring bags up for grabs. So please pay attention to Doc. Also, if you let me know who wants to win, let us know in the comment section. And if you have any questions as well, feel free to ask us throughout the interview, throughout the show, and we're going to address it right at the end. Okay, sounds good? Let us know. Okay, Doc, um,
Yes,
before we
Nina.
begin, can you share a little bit about yourself and what exactly do you do? When it comes to colon cancer screening and oncology. Yeah.
Okay, yeah. My full name is Dr. Ahmad Khairil Irham Harun. Okay, I'm originally from Selangor. Okay, but now working in Colombia as a Bintulu. Okay, I am a general surgeon, consultant general surgeon, and I deal mainly in the diagnosis, the treatment, and also the post-op care of patient with colon cancer. Okay, so it is one of my main interests is including the screening and prevention of colon cancer, as this is quite a prevalent disease in our community.
Okay. How did you get started in oncology, Doc, and why colon cancer?
Um, I would say it's grew up on me in part of my practice in general surgery. We tend to see a lot of these cancer patients, especially colon cancer,
Mhm.
and it's one of my interests in the treatment because I do see that a good surgery would offer much benefit to the patient.
Ah, right. So it makes a lot of difference. Okay, got it. So
Yeah.
why is it important that we talk about today's topic, colon cancer screening? What are our options? What are you hoping the audience will take home?
Okay. Firstly, this is the month of March. Actually, this is the month of colon cancer awareness. Most of us probably would hear more about breast cancer awareness programs. So I would just like to bring this topic to the front, okay? Because colon cancer is actually one of the most common diseases of malignancy in Malaysia. Okay, it is now actually the second most common disease in Malaysia and actually causing the second highest cause of mortality for cancer patients in Malaysia.
Okay, so it's a very big deal, kind of thing in Malaysia. Yeah.
Yeah,
Okay.
in terms of the patient numbers, and we also do have programs and also options for screening, which can help patient in the long run for the outcome.
Okay, got it. And I heard that the number is reducing the number of deaths because of early screening. Is that true? Or
Yeah, you
compared to
do see
before?
this. Yeah, you do see this reduction in death mortality because of colon cancer, especially in more westernized countries. In Malaysia, also we see the numbers is slightly reducing, but not much a lot because I think our community is still there is still lacking awareness of colon cancer screening.
Okay, so that's why it's important that we talk about today's episode so that people are aware about the importance of the screening. Yeah, sounds good.
Yes, definitely. Yeah.
Okay, if you guys are ready, let's begin. Okay, so first things first, let's go into the slides. Yeah, waiting
Okay.
for the
Yeah.
slide. Okay, so colon cancer screening. What are our options? Okay, let's take. What is this? Before we begin, what's this slide about? Yeah, doc.
This is just a declaration that I don't actually receive any financial incentive for any of the tests that I recommend, or even
Okay.
the equipment that I use for screening. But I do run a private consultation practice here in Colombia.
Okay, got it, got it. Okay, and then we spoke about your personal background, so let's go into the third one. Okay, doc. So before we start talking about colon cancer screening, I think we need to start with the basics. What exactly is the colon? Where about is it? And what are the
Okay,
functions? Right.
yeah. So for this disease, we tend to hear the term colorectal. So actually, it's two parts: colon and rectum, and both are actually different entities, are different organs. Okay, so the colon in the lay terms is what we call the large intestines. Okay, is a continuation of the small intestine, usually located in the abdomen. There are several parts of the colon. Nina, can you forward the slides a bit?
Okay.
The next slide, another one.
Okay.
Okay, so the colored part is actually the part of the colon. Okay, it started at the cecum, where is the most proximal part of the large colon, and ends at the sigmoid colon. Okay, there are several parts that most people tend to hear, but don't think it's related to colon. I think most people will hear about the appendix. Okay, a lot of people are admitted because of acute appendicitis. Okay, so actually appendix is connected to the part of the colon, the large colon, especially the cecum. So we name the colon so to make us classify and also to make us better inform the location of diseases in this part of the colon. So the colon is actually is about 1.5 meters in length in an adult. Okay, so it's the continuation of the small bowel and it actually ends at the rectum. Okay, Nina, can you go the next slide? Okay, the
Okay.
color part now is the rectum. So once the colon ends at the sigmoid colon, it is the start of the rectum, and it's actually in continuity until the anus, the opening of the hole where we pass the feces. Okay, so in terms of function, can you go for the next slide?
Okay.
Okay, so basically, colon, the main function is main absorption of water and electrolytes in the body. If you have a patient with diarrhea, okay, they can develop severe dehydration because of this. Because the main function of colon is the reabsorption of this water and prevent our body from becoming dehydrated. Okay, the next function is some production and also metabolism of certain vitamins, especially vitamin B and vitamin K, which is important in our body functions. And lastly, for the rectum itself, it doesn't hold much of function in terms of absorption, but it mainly forms the feces and it holds the feces before we go to toilet for defecation.
Okay. Got it. So that's it. Yeah. So
Yeah.
in today's episode, what are we gonna be covering? Yeah, doc.
So I'll touch a bit on why colon cancer is a big thing in Malaysia. How common is it? Okay, and in terms of the numbers. Okay, and why we actually choose colon cancer for screening, why we recommend colon cancer screening. I will also touch a bit on who should undergo screening, okay,
Mm-hmm.
and what are the methods available, especially in tertiary centers like Colombia, as Bintulu, and how
Mm-hmm.
often should they be screened if they already done screening. And lastly, I would just touch a bit on how do you uh, how do you get the arrange a consultation for screening for colon cancer.
Okay, got it. Sounds fantastic.
Yeah.
Okay, so let's go. So let's talk about the incidence here, Doc. Is colon cancer
Yeah.
very common, and why is it so common?
Okay. Firstly, in 2012 to 2016, is about 100,000 plus of cancers are reported in Malaysia alone. Okay, and about 15% of that is colon cancer, which make it the second highest common cancer in Malaysia, just after breast cancer. And this colon cancer affects both side of the gender, male and female, almost equally. Not only that, colon cancer also is the second highest cause of cancer mortality in Malaysia. So this is mainly because of late diagnosis, which cause a lot of the mortality that we think that can be avoided if you undergo screening. Why is colon cancer is quite prevalent in our country? Is a bit complex uh, causation because cancer is multifactorial. Okay, there's a
Mm-hmm.
risk factor associated with age. The older you are, the higher risk of you getting any type of cancer, including colon cancer. Okay.
Mm-hmm.
Second is our lifestyle, obesity. Malaysia is the highest, is the most obese country in Asia. Okay, so I think that's one of the causative factor of a lot of colon cancer in Malaysia. Okay. Thirdly, is also related to the diet. Okay, diet high in processed food, high amount of salt. Okay. We also like diet which what you call that? Which a lot of
Lacking
burn
vegetable.
chemical. I mean, like yeah, carbonized food. Okay, ayam panggang, daging salai, all like that. Those
Satay, all that.
actually they contain some chemicals that may contribute to colon cancer too. So
Okay, so
in
it's
a bit, it is very multifactorial, and there are a lot of causes that would cause a lot of these high incidence in Malaysia.
okay, got it. So basically, it's because of lifestyle for us, even though it's multifactorial. Yeah.
Lifestyle is
Okay.
a main part of it. Okay, some part
Mm-hmm.
is genetics, but in Malaysia, and even the whole world, genetically associated colon cancer are not quite common. It's quite rare actually. Probably less than
Okay.
2% of the whole colon cancer. Yeah.
Wow. So definitely we need to look into lifestyle, and that's because of the food that we take. A lot of processed food.
Definitely
Okay.
yes.
Okay, got it. So why screen for colo? How does one know that they have colorectal cancer? Just wondering.
Okay. When you ask how do we know, is
Yeah.
we're looking for the symptoms of colon cancer lah. Okay.
Mm-hmm.
There actually is quite varied in presentation, and patient can present in a lot with a lot of symptoms. The most
Okay.
commoner one include is changes in the bowel habit. Some day they may
Mm-hmm.
be constipated, some day they may have diarrhea. Okay, sometimes those changes of bowel habit tends to trigger a red flag in doctors for colon cancer. Okay, secondly, bleeding from the rectum, meaning there's blood in the feces when passing feces. Okay, those are also a
Mm-hmm.
cardinal sign of malignancy in the colon. Thirdly, some symptoms can be very vague. You can have like abdominal pain, which is not specific. Sometimes can be on the right side, sometimes can be on the left side, sometimes it can be the whole abdomen. Okay, so some symptoms are not specific. Some also present to us with the feeling of unwell, unable to eat. Okay, losing weight, quite a lot of weight usually. and also some can also be diagnosed by certain blood tests only, like a low blood red blood levels in the body.
So, doc, by the time these symptoms come up, is it very early on or quite late the stage? Just wondering.
Okay, the symptoms tends to only develop in a later stage of cancer. Okay, so
Right.
usually once the cancer become big enough, only do most patients have symptoms. And this is why we are promoting this colon cancer screening. One is
Mm,
because colon cancer, we actually there's a lot of study on this colon cancer for quite a long time, and we actually have enough information to understand its biology. Okay, colon cancer tends to start as a polyp, which grow and turn into cancer. So these are the things that we are targeting during the screening for colon cancer. Why we do this screening? Because we also have the the the, the accurate test to check for colon cancer and pre-colon cancer diseases. Okay, by diagnosing, by identifying this pre-cancerous lesion, we can actually prevent cancer. Okay, I
wow.
think most of people, one of the misconception of cancer is cancer always causes pain, but this is hardly seen in our clinical practice. You only have pain if the disease is quite severe or very serious. Okay, so we tend to see patient without any symptom which was diagnosed only on screening. So that's why we are promoting this colon cancer screening.
I
Okay,
see. Okay.
by identifying this colon cancer early or this precancerous lesion early, okay, we also would improve. We tend to improve the outcome because if you diagnose a disease early in stage one and stage two, the likelihood of curing from cancer is more likely than curing from stage three or stage four disease. Uh, because of this early stage, also we also have more alternative treatments. We also have scarless endoscopic surgery for certain types of colon cancer, and in the long run would reduce the cost of treatment overall because the advance of the disease requires more multimodal treatment, including chemotherapy, large surgery, radiotherapy, and now with the advancement of targeted therapy also. So there are a lot of options now, but in terms of cost, they will rack up if as the more advanced of the disease it is.
Okay. So basically, I think to summarize all that, you only feel the symptoms once it's really advanced. When it comes to cancer,
Yeah.
it's usually no pain. So the best cure for cancer, especially colorectal, is to get screening early because then you can get intervention early as well, right? And the best
Yes, I
of
agree,
the
Nina.
treatments. Okay, fantastic. I
Yeah.
think that's super clear. Thank you so much. So what are men more at risk than women when it comes to colorectal, or it's the same? Who is normally at risk?
Okay, yeah. Actually, men are more tend to get colon cancer compared to women, but the
Hmm,
difference is not that big. Okay, so it's about 1 to 25, 1 to 20 over one every 22 men will more likely to get colon cancer compared to women. Okay, but
I see.
this risk actually increases over 50 years old. So even men can go up to 1 in 15, every 1 in 15 patient can get colon cancer among men above 50. And this trend also is also seen among women who is above 50.
Okay,
But overall, yeah, men tends to get colon cancer more common. This is probably attributed to a higher risk in men. There's more men smoking, and men tends to uh, avoid getting screening or therapy in hospital compared to women.
I see. Okay, cool. So men are more at higher risk, and so who should be sorry, who should be screening, doc?
Okay.
Yeah.
For screening purposes, what we generally say to most person, okay, once you achieve above 50-year old, okay. now experts in Westerners are recommending above 45 because they see that starting screening earlier also can give benefit for person above 45. Okay, but we
Mm-hmm.
generally take the age limit up to that around 45 to 50. Okay, anyone who is at risk, okay, including having first degree family member, meaning brothers, sisters, okay, parents with cancer, they are at higher risk of getting colon cancer. So we encourage them for screening. Okay. Another one which is higher risk group is that person, the patient himself who already had a previous colon cancer before. They are at higher risk of getting a second colon cancer. Okay. The fourth one, a patient with inflammatory bowel disease. This includes Crohn's disease. This includes ulcerative colitis, because all these inflammatory bowel disease tends to cause scarring and repetitive trauma to the bowel, which can bring up to cancer.
I
Okay,
see.
genetics
Okay.
like the one I told you earlier.
Mm-hmm.
Okay, but this is not a common cause. But we do see on and off people with what we call as familial adenomatous polyposis syndrome. Okay, it's an inherited disease. Okay, which can predispose patients to getting cancer at a younger age, sometimes as early as 18 years old. Okay, and for the lifestyle part, people who are smoking, okay, people who are obese, okay, people who are taking food high in processed food, high salt, and all those charred foods, they are at risk of getting cancer. So these are the community that we try to get to go for screening.
Okay, got it. Okay, so let's take a look at the next slide. So, who should undergo for screening? And if we have symptoms, do I go for
Mm.
screening? Well, I think you answered it earlier. Before we get the symptoms, right? We don't wait for it.
Yeah,
Yeah.
screening in the principle itself, if we check for disease before it is there, meaning there's no symptoms, and most likely there's
Mm-hmm.
no disease yet, and we are checking them for it. Okay, once
Okay.
someone has the symptoms like the one I told, bleeding,
Mm-hmm.
having abdominal pain, okay, having any mass, okay, having loss of weight, having loss of appetite, okay, those who are we think that the symptom may suggest of cancer. Actually, we don't recommend them for screening. We usually will counsel them directly to go for a diagnostic colonoscopy.
I see. Okay. Because that one dah ada symptom kan?
Yeah, because the
Bila.
symptom they preclude them from screening. So the best method to check for them for diagnosis is directly for colonoscopy. But if screening is
Okay.
different, we have a few options besides colonoscopy.
Okay. Got it. Okay. Let's take a look at the next slide here, Doc. So what methods of screening are available?
Okay, I think it's the
Wait,
next
sorry. So
slide.
this is talking about
Yeah,
symptoms, right? Sorry.
yeah.
Okay. So,
I think
so
we touched a bit on it already.
okay, got it. So we'll go to the next one. 16. Okay, so what are the methods of screening available and how do we know which one is for us?
Okay, so basically there's two groups. Okay, one we
Mm-hmm.
call as non-invasive, and the second group we call as invasive screening method. Okay, the most I would say popular, not to say popular, but I mean the most the test that is most likely to be acceptable to most people is probably the fecal test. Okay, this
Mm-hmm.
test is the first two one, like the fecal immunochemical test and the fecal DNA testing. Okay,
Mm-hmm.
because this test one is non-invasive. Okay, second is the most cheapest test that we can do. Okay,
Mm-hmm.
thirdly, it can also be done at home. Okay,
Mm.
the test is something like remember COVID.
Oh
It's
yeah,
like
yeah.
our
So
COVID
something like that.
RTK test. Yeah, it's actually something like that. Okay, but the difference is the sample we take from our stool. Okay, okay,
Mm-hmm.
we will teach them how to collect the stool sample from the toilet bowl. Okay,
Mm-hmm.
okay, we
Mm-hmm.
dip like a it's like a dipstick in. We put a stick into the feces. Okay, and the
Mm-hmm.
feces is put into the buffer solution, like the one we do for the COVID test. Okay, and then
Ah,
you
okay.
wait for the line to come out.
Oh,
Okay,
okay.
what? Yeah, after this we will have a picture to show. And you will see it's almost similar to the COVID test. Okay, so
Okay, got it.
and the result will come back as either positive or negative. Okay,
Okay.
if because this test actually tests for blood in the stool.
Oh,
Uh,
I see. Okay. So if
yeah.
it's positive, it means you have cancer, or it. What does it mean?
Oh, oh, okay. Later, I think we will touch a bit when we
Well,
can we see the next slide first. Yeah, I show you a bit.
okay. Do you want to cover the invasive and CT colonography before we go to the next one, or we can go to the
I
next
think
one
we'll come
directly?
back to this slide after I
Mhm.
just talk a bit about the fecal testing.
Okay, so this is the fecal testing,
Okay.
right?
Yeah, this is a fecal test, but some of the packaging may be different in different hospitals. Okay, but
Mm-hmm.
when you see, it will remind you of that COVID test, right? Okay,
Mm.
it's almost the same. Okay, there's a buffer solution. We take a specimen from the stool, not take from the
Mm-hmm.
nose. Okay, and
Okay.
we dip it into the solution,
Sure.
and
Uh-huh.
the solution will be mixed with the chemical reagent inside the solution. And after that, this in this picture, it shows that they shake and see the change of color in the test. Okay, some of
Mm.
the tests we need to drip the solution back into the RTK like container for it to come out the result as positive or negative. Okay,
Mm.
so in
Okay.
the sensitivity of this test is about 90%. Okay, what does
Okay.
sensitivity mean? Meaning if you don't have the disease and the test came back as negative, 90% of the time you don't have the disease.
Ah,
So it
okay.
is quite accurate to say that you don't have the disease. Okay,
Basically, it's
but
90% accurate lah.
yeah, around there. Okay, so in terms of specificity, if the test turn out to be positive, there's about 90 to 95% that you have the disease.
I
Okay,
see. Okay.
meaning
Okay. So
cancer
that's
lah.
pretty
Okay,
accurate.
so there's a
Oh, okay.
5% difference. It's not 100% test. At the moment, there is besides colonoscopy, there's no 100% screening method lah.
Mm. Okay. Okay.
Okay,
Okay. Got it.
yeah. So
All right.
actually, when you ask if you are positive for the test, do you have colon cancer? The
That's
answer is you may have, but
right.
it may be another disease because some other disease also can cause the presence of blood in the feces.
Okay. Got it. So
Okay, so
basically,
I
if
think
it's
we'll touch
tested
on that a bit.
positive,
Yeah.
yeah. So basically, if it's tested positive, then Houston, we have a problem. You need to go and check further.
Yeah, you need to
Basically,
actually do the more invasive testing to confirm what you have.
okay, got it. So this is the
Okay.
two. Do we go back to the slide then?
Yeah, we go for to the slide before. Okay, so that's why I said this is will be the most acceptable test because
Mm.
it's starting to be the least invasive one. Okay, the cheapest one
Mm-hmm.
you can do at home, and actually is recommended to do it repetitively because one wrong test. But if you do it more than one, the likelihood of a wrong test will be lesser.
Lesser. Okay, got it.
Yeah. Okay.
So
So
this
the
one is
next
the
on the
this
yeah.
one is the first one or the second one or both?
Actually, the method is the same, but what we are testing is a bit different. Okay. One
Okay.
test for blood. Okay. The second,
Mhm.
the fecal DNA, is tested for abnormal DNA in the feces. Okay. In terms
Mm.
of in practice, the fecal DNA testing is a bit more expensive, but it's
Mhm.
more specific for colon cancer.
I see. Okay.
Yeah, so if the test turn out to be positive, you are more likely to have colon cancer compared to the fecal immunochemical test.
I see. Okay, so that's the fecal DNA one, yeah?
Yes, that's correct.
Okay, got it. Do you normally tend to recommend them to do both, just out of curiosity?
Uh, I tend to just do the fecal immunochemical because it's in terms of uh,
To
what
go
do you call that?
straight to the
The,
point.
the the price and usually because if it's positive, I would definitely still need to do a colonoscopy.
Okay, got
So
it.
in my practice, I do the fecal immunochemical testing and then if it's positive, I certainly do the colonoscope. But some
Oh,
people who are still not, I mean, not convinced, some may need to do a second fecal DNA test. Yeah.
okay, got it. Okay. And what is the CT colonography?
Okay. Have you heard of CT scan, Nina?
Yes.
Okay. CT scan basically is like a more advanced X-ray lah. Okay. Where instead of
Mm,
one X-ray picture, we take multiple X-rays in a few seconds. Okay.
mm,
So CT colonography basically is a CT scan of the colon. Okay, so what we want to see is basically a CT scan of the wall of the colon. Okay, what we are looking for is abnormalities in the wall of the colon. Okay, including sometimes you can see polyp larger than 1 centimeter lah. But the
mm,
downside of this is I don't think sometimes it's not necessarily can be done everywhere lah, because there's a certain there's a specification for the CT scan machine itself. They need to be able to scan up to 0. I think about 2 millimeter thickness. So I think most of
okay.
the newer CT scan can be done with for the CT colonography, but probably centers with older CT scan cannot do the CT colonography.
Okay.
Okay, so
And what can you
like
tell?
a X-ray, like a CT is tend to be preferred because it doesn't involve any scoping or any blood taking or such lah. So some people want that test. But the other downside is sometimes you cannot differentiate feces from polyp in the CT scan. So some may still need to do a invasive test after that.
Okay, got it. And so that is CT colonography. And
Yeah.
the invasive tests are?
Okay. For the invasive testing that we are available is one is a flexible sigmoidoscopy and the second is a colonoscopy. If you remember the earlier picture about the colon, okay, the most the last part of the colon is called the sigmoid colon.
Mm, okay.
Okay, yeah. So
Mm-hmm.
flexible sigmoidoscopy is actually a scope endoscopic examination up to the sigmoid colon.
Okay.
So it's something like a lesser colonoscope.
Mm-hmm.
Okay. Well, who do we do it? Because in the studies, 70% of cancer actually happen on the left side of the colon. What I mean on the left side is the last part of the colon. So if we find any lesion on the left side of the colon, okay, that will prompt us to complete the examination with another colonoscopy.
Okay. And this photo is a sigmoid
Okay,
endoscopy
for this
or?
photo,
Mhm.
is a graphic of a operator doing this is a colonoscopy where you see
Uh,
the scope end is reaching
mhm.
the almost the appendix there.
Okay.
Can you see at the back? Yeah. Okay. So this is an example
That's,
of a colonoscopy, and the bottom part of the picture is actually some example of what we can see during a colonoscopy or sigmoidoscopy. Okay. The
ada
A,
orang tutup mata, tak?
yeah.
Ada orang tutup mata. Hmm.
Yeah, this is what it looks like during an actual colonoscopy. This is actually not my picture. I took it from a journal, but it's just
From
an example of what we can see in the colonoscope. Okay, the
and
most
these are
left part.
polyps or what? Dog.
Okay,
The
the
yeah.
A picture is what we call a polyp lah. Okay,
Okay.
this looks mostly like a benign polyp. It looks small.
Mm-hmm.
Okay, it looks regular. Okay, and
Mm-hmm.
it's just slightly raised from the surrounding tissue. Okay.
Mm,
Compare that
okay.
to
And the
B. Yeah, B is like a bigger part of a polyp. Okay, more irregular in shape. Okay, and some parts are a bit folded and some part are a bit depressed. So this is what we call an advanced polyp. So this polyp can be benign or it also can tend to hide malignancy cancer in it.
mm. And
Okay, the
the
last
last
one, the
one?
C. there is
Mm.
almost definitely a cancer. Okay,
Why
why
almost
do I say?
definitely? Yeah.
Because because you know lah, medical anything can happen. Okay,
Okay,
in
got it.
medicine, yeah, anything is possible. Okay, there are some disease that can appear like cancer. Okay, that's why I
Wow.
say
Okay.
almost definitely. But looking at that, okay, there's a irregular shape. Okay, there are part that is depressed, and is some parts are bleeding spontaneously. Those tends to be apa the tell sign of a cancer lah.
Okay. Let's look at the next slide. Yeah, doc. This one put colonoscopy ke macam mana?
Yeah, this is part of the colonoscopy, but what we actually do for the lesion that we find lah. Okay, on the left side, okay, the one with the with the instrument probing it
Mm-hmm. Mm-hmm.
is an example of we can able to take biopsy tissue biopsy from whatever part is abnormal. So
Okay. Got it.
that's how to differentiate is it cancer or not cancer. Okay,
Okay.
we send it for testing in the lab. Okay, and
Mm-hmm.
the pathologist will look it under the microscope and say back to us is it cancer or not.
Okay. And the photo on the left?
Okay, the photo with the four parts is actually an
Mm-hmm.
example of a polypectomy. Okay, like I
Mm-hmm.
said, some cancer, about most cancer originate from a polyp. Okay, so if we
Mm.
remove the polyp, okay, we prevent the formation of cancer. So that is what we can intervene and prevent cancer lah. We can remove the polyp in the same setting as the colonoscope.
Okay, so memang boleh sembuh lah.
Insyaallah.
Inshallah.
Yeah.
Okay, Doc, I have a question. When you say colonoscopy, the invasive one, let's go back.
Yeah.
Colonoscopy and sigmoid, whatever ni. When you say
Yeah.
invasive, because I cannot imagine it because I've never experienced it and I would like not to experience it, cancel.
Okay.
What is it? Are you putting a camera inside this? Di kot mana? Because colon to 1.5 meter. Is it going around 1.5
Yeah.
meter? Because that's kind of scary, you know? So,
Okay.
macam
So
mana tu,
so
Doc?
so how do we do the colonoscope? Usually the patient is lying down on the left side. Okay.
Mm-hmm.
The scope itself is a long tube with the camera at the end. Okay. So
Okay.
the scope is inserted through the anus. Okay. Usually
Okay.
when we do the colonoscope, we will give the patient sedation.
Okay.
Okay, it's a bit
So,
uncomfortable because during the examination we will pump a lot of air to see the internal of the colon. Okay, but
okay.
usually most people can tolerate with sedation. In some patients they will require a bit of general anesthesia if they can't tolerate the pain.
I see. Okay. So,
Okay, so
okay.
once we insert through the anus, okay, the scope is advanced until the end of the large bowel, which is the cecum. It is
Okay.
only
And
complete if we can reach until the cecum.
okay, got it. So the sigmoid apa ni? Sigmoidoscopy
Sigmoidoscopy is
the
yeah,
same?
it's just until the sigmoid colon. Okay,
Okay,
if
got
you
it.
do a full colonoscopy, you go beyond the sigmoid colon. You go until
Okay,
the
got it.
cecum. Yeah.
Okay. So is everybody clear? I hope you're clear. I'm just feeling uncomfortable. That's all. So if they get apa anesthesia, is it? So does that mean they're
Yeah.
awake or they're awake when the process happens?
Okay, like I said, most people tend to tolerate the procedure under sedation, meaning they may be partially awake, but most of the
Uh-huh.
time they won't remember the procedure after that. Okay,
Oh, that
there's
sounds
also
good.
yeah, we also give a bit of painkiller during the procedure itself. But some
Okay.
do request for general anesthesia for the procedure, and we will assess and we will counsel them accordingly lah.
Okay, I think I'm definitely going for the general anesthesia thing. Okay, because I'm a chicken. Okay, cancel. Okay, so which goes to the next question. So now that we know what are the methods of screening, how
Hmm.
often should this be done? How often should we go for screening?
Okay. Okay, recommendation by all these professional medical bodies for colon cancer screening is uh, if in asymptomatic patient above 45 or 50-year-old, okay, you should go for the fecal testing at least annually. Okay, why we are doing annually? One, like I said, if the first test turns out to be wrongly negative, okay, the second test may detect it. Okay, so by doing it repeatedly, okay, in an annual basis, it actually increase the catch rate of the test. Okay, so from a 90% sensitivity, it actually can increase up to 99% if you do it more frequently. Okay, and but the
Okay.
recommendation is just annually. You don't really need more frequent than that. Okay.
Okay. Got it. Annually.
Okay.
Okay.
The second one, the fecal DNA testing. Can I go
Okay.
back? Yeah. Okay.
Yes. Yes.
That is recommended about 3 to 5 yearly because uh, usually it is recommended as a supporting screening with a fecal immunochemical test. Okay. Because of the cost and all. Okay. But if you already if it's a negative fecal DNA test, it's recommended to just repeat in about 3 to 5 years time. Okay.
Okay. Okay.
Okay, lastly, the colonoscopy, which I would say it is the gold standard for any colon cancer screening. Okay, if you have done
Mm-hmm.
a colonoscopy this year and the result is negative for cancer or polyp, okay, you as I would almost say it is safe to say you will not need another scope for the next 10 years.
That's good.
Yeah, because
That's
it is a very thorough examination during the colonoscopy. Some can take up to 1 hour.
wow. Okay. Okay. Hmm. Okay.
Okay,
Sounds good.
the other the other tests like the sigmoidoscopy and the CT colonoscopy is usually recommended 3 to 5 yearly.
Okay. Got it. Okay. So let's go to the next one. What should I expect? Yeah, doc.
Okay. If a person comes and requests for screening consultation, okay, for colon cancer, these are the I think we say the minimum would you expect from your doctor lah. Okay, usually the
Mm-hmm.
consultant it can depends on the center. Okay, like in Bintulu mainly usually cancer are dealt by the general surgeons lah. Okay, like me. Okay, so you have a screening. The consultant will take a full history from you, okay, including the family history, the history of previous malignancy, okay, a
Mm-hmm.
history of underlying diseases, okay, and history of underlying bowel disease like inflammatory bowel disease, and that would increase the risk of getting cancer, okay, and we will complete a physical examination, okay, and this will be supported by some of the laboratory tests, including the fecal immunochemical testing lah. Usually the most recommended one for asymptomatic in the 50-year, we will start the most less invasive one, meaning the fecal immunochemical test. Okay, and
Mm-hmm. Mm-hmm.
we would discuss all the screening method beforehand. What
Okay.
it means by screening? Okay, how what is the accuracy rate? What is the of the screening each of the screening method? And like the question you asked me, which one is the best for you for screening? Okay, this
Mm, yeah.
would it will be tailored according to the patient's history and risk, and also the patient's what do they want lah, basically. Okay,
Mm.
because
Okay.
some really don't want to do a colonoscope if they can avoid it. Okay, so some we
Mm-hmm.
need to consider colonoscope from the early on, but if they don't want it, we can't really force on them because the risk of the procedure itself is on the patient. Okay, as a consultant, we can only advise and proceed with what they have consented for.
Okay.
Okay,
So,
okay.
doc,
So once they do the screening and chose the screening test, okay, we will
mhm.
usually have a follow-up consultation and a recommendation on how to go about how if we need to repeat any test, okay, or how often should we meet back for follow-up.
Okay, sounds good. Doc, this looks very clear, step by
Mhm.
step, but in your experience with patients, it can be quite scary, right? Especially when you
Yes.
find that the results are positive. So, in your experience, where is it that that could be scary for patients? What is it that most patients need to know from your perspective? Yeah.
Okay. For me, the first misconception is always the most frequent one we find lah, because
Mm,
uh, usually they came to us when they already done a screening somewhere else, probably in a clinic kesihatan or probably in
uh-huh,
a government hospital, okay, and they
mhm,
come ask for the test, okay. But I think most people still have the denial aspect. They can't accept there is possibility of cancer. Okay, so when we
mm,
counsel for invasive method, some of them would default from treatment or don't come for follow up. So my advice on patient is, yeah, because some patient, what we don't know won't hurt us, right?
yes,
That
yes,
is the most
exactly.
one of the yeah, for Malaysians, right? So uh,
Mm,
we should change that mindset lah, basically. Okay, it
okay,
is good to know what is happening to our body. Okay, uh, when we do a screening test, it is not that the doctor put the disease in the body. The disease is already there. We only done the test to confirm there's a possibility of the disease, get that disease, and we are going to check it out and offer you treatment if it's confirmed. Okay, so
okay,
I think that mindset should be we should think from that mindset.
okay, got it. That it's for healing, that we can prevent and
Yes,
have a better life quality if we get it early. Yeah.
yeah,
So rather than
definitely.
not knowing, we need to face what's actually happening. Yeah. Okay.
Yeah,
So
we need to take a bit of responsibility for our health. Yeah.
okay, that's a very good topic. Responsibility for health. Okay, so Doc, how do we get in touch? Where can someone get advice from you, or how do they get in touch with you? And what if they're not in Bintulu? Yeah.
Okay. So I am practicing in Columbia Asia Bintulu. So my clinic is every
Mm-hmm.
day 8 to 5, including Saturdays until 1 p.m. lah. Okay. But
Mm-hmm.
if someone is not from Bintulu, let's say in Selangor area, okay, Columbia Asia have a oncology center in Bukit Rimau. You can
Mm-hmm.
actually get the contact number from the website of Columbia Asia Hospitals, and
Mm-hmm.
someone there can arrange an appointment with your preferred consultant, lah, whether a gastroenterologist or a surgeon.
Okay. And also, if you guys are not in Bintulu anytime soon, screenings are available at almost all Columbia Asia hospitals nationwide. So we're talking cancer screening, colonoscopy, endoscopy. So definitely look up the nearest branch to you and make that appointment, because detecting it early can save can save your life. Yeah, kind of thing.
Yes, yes.
So yeah. So, Doc, at the end of the day, we've spoken about the
Mhm.
screening and the all the things. What do you want people to take home? What is the take
Okay,
home message
so
of the day?
uh, firstly, I would like our viewers to understand that cancer can happen to anyone. Okay, just
Mhm.
because someone is young, it's not that he can have cancer, lah. Okay, so if someone have symptoms, definitely please seek urgent medical consultation, and your doctor can discuss with you the available options. Okay, so but among the asymptomatic person who is at risk, okay, the one with the 45 year old or older, okay, someone who has family members with cancer, okay, someone who's probably smoking or obese, okay. So this patient I encourage to undergo yearly fecal testing for colon cancer. So by diagnosing early, okay, we can actually prevent before the disease for cancer happen. Okay, so and in the
Okay.
long run that would actually improve the quality of life.
Fantastic. Thank you so much. Give Doc Kyril a round of applause. I think now we've learned a lot from this episode, but we're gonna go into Q&A because I'm sure there's so many questions that you guys have. So the first question is from Momo. Momo, always ever so curious. Momo is asking, cancer ni apa sebenarnya ya Doc? Dan macam mana nak cegah? Kalau dah ada cancer ni, apa rawatan selain chemo?
Okay, so the question is given in Malay, so I jawab in Malay lah. Ha? Okay,
Okay.
cancer tu sebenarnya dia pertumbuhan sel yang tak normal. Okay, jadi sel tu berasal daripada sel badan kita sendiri, tapi pertumbuhan dia tu disebabkan oleh macam merokok ke, kesan sinaran ke, radiasi, certain penyakit jangkitan, dia menyebabkan sel-sel yang tak normal ni menjadi tidak normal. Jadi pertumbuhan dia makin besar dan dia menyebabkan dia boleh menjadi kanser. Jadi kalau dari segi pencegahan kanser tu adalah secara umum dia kita jalankan kehidupan yang sihat lah. Makanan kena jaga, jangan berlebihan. Kalau obesity tu tingkatkan aktiviti kita, exercise, dapatkan berat badan yang ideal. Elakkan pemakanan yang banyak proses tu, seperti makanan tin, mi segera, jadi cuba banyakkan makanan-makanan yang segar, yang masak sendiri. Jadi dan sebab ada faktor yang kita tak boleh elakkan macam keturunan semua tu. Jadi benda yang kita boleh kawal tu yang kita cuba ubah untuk jadi lebih sihat. Rawatan dia bergantung pada kanser. Kalau kanser usus, rawatan utamanya biasanya pembedahan dan follow by kemo lah. Tapi lain-lain kanser macam kanser darah, mungkin rawatan utama dia kemo saja. Jadi yang ini dia memang berlainan lah. Lain bahagian kanser dia lain punca dia punya rawatan dia. Dan saya harap Momo boleh dapatlah maklumat.
Ya, Momo is saying terima kasih doktor bagi betul-betul penjelasan dengan sangat clear. Cik. Well done. Okay, so two more questions for Momo. I'm going to combine it together. Doktor nak tanya, kalau kerak sembelit, adakah ia berisiko ada colon cancer? And golongan usia berapa saja yang berisiko ada colon cancer? Can kids juga berisiko ada colon cancer? Somebody else also asked that question.
Okay, saya sentuh yang second part tu, bahagian kedua tu dulu. Adakah kanak-kanak berisiko dapat colon cancer? Ya. Tapi jarang-jarang. Colon cancer lebih kepada berusia, tapi bila saya kata biasa tu maksudnya ada kemungkinan juga ada kanak-kanak yang akan dapat colon cancer, tapi jarang-jarang kita jumpa. Kanak-kanak yang ada risiko dapat colon cancer dia macam biasanya kanser disebabkan keturunan yang FAP tu. Familial adenomatosis polyposis. Yang ni memang biasanya keturunannya memang dalam anak beranak sendiri banyak orang dapat kanser usus. Jadi yang ni kena jaga-jaga. Golongan yang memang semua orang boleh dapat kanser, tapi kita lagi commonly jumpa dalam pesakit yang lebih berusia lah, lebih daripada 50 tahun. Tapi walaupun begitu jangan sangka kalau kita muda tu bukan tak ada kemungkinan dapat kanser lah. Jadi sebab tu bila ada tanda-tanda macam sembelit, sembelit kebiasaannya mungkin dalam 10 hingga 50% saja yang disebabkan oleh kanser. Jika sembelit itu berlarutan, ataupun jika memang kamu ada risiko lain macam usia sudah meningkat, merokok tu semua, saya nasihatkan datang jumpa doktor yang kamu prefer dan dapatkan konsultasi lah. Jadi doktor tu akan menjalankan pemeriksaan yang menyeluruh, baru kita dapat bagi tahu adakah disebabkan oleh kanser ataupun tidak.
Okay, got it. Okay, Doc, very clear. Everybody saying thank you. Annabelle, RUU semua, yeah? From Yu Kyong, is someone have a colon or rectal polyp means he have cancer and need surgery? Is that true, Doc?
Okay, kalau Yu Kyong, if you say about polyp, polyp is abnormal growth. Nina, if you don't already know, polyp is an abnormal growth in the colon or rectum. But polyp does not mean cancer. The rule is all cancer starts from a polyp, tapi not all polyps are cancer. Tapi polyp ni is a precursor for cancer. When polyp are left alone long enough, they can grow big and eventually turn to cancer. So if undergo colonoscopy, usually we will identify this polyp and we will remove it during the colonoscopy. So by removing the polyp, we will prevent a future occurrence of cancer. But the polyp itself doesn't mean that you have cancer.
So during a colonoscopy, you can actually remove the polyp as well.
Yes. The one
Okay.
the second picture with the apa, I think one of the pictures that we have in the slides.
Uh-huh.
Okay, we do what we call a polypectomy lah. We cut off the polyp.
I see. And
This
once you
is
have a
this is during colonoscopy, not during surgery. This is during colonoscopy.
okay, that's bagus. You should do a colonoscopy then. So when you remove it, does it come back? Kind of like, they say fibroids, when you remove, the occurrence of it happening again is high. Is it the same with polyp?
Okay, for endoscopies, we tend to try to remove it in whole, meaning up to the base of it. Okay,
Okay.
sometimes certain type of polyp we can't remove the whole part. Okay, those tend to recur again. Okay, but usually if we able to remove everything on the first go, usually we still need to monitor for surveillance for repeat scope to see whether it occurs again. Tapi usually it doesn't grow back lah.
Okay, 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 okay. Okay, fantastic. Okay, so Mat Dean also has a question. Dia kata, "Hi doktor, colon cancer, usus harus kena potong ke? Kalau buat pembedahan bariatrik, ada risiko kena colon cancer?" I have no idea what that means, but do shed some light. Doc?
Okay lah, bariatric. I think he's meaning bariatric surgery is the weight loss surgery. Okay.
Okay.
Um.
Yeah, okay.
Okay. Does bariatric surgery increase the risk of cancer? I would say no. Okay. But some issue of bariatric surgery is worsening of reflux. They can have increased risk of getting esophageal cancer, cancer of the throat. Okay. But I think generally, if you do bariatric, if you lose weight, it's actually protective for colon cancer. You are less risk of getting colon cancer. Okay. The first part of the question tadi, does the usus need to be operated ke tak if you have colon cancer? Depends on the stage of the disease. Okay. Some very small, very early cancer, we can even treat it curatively with colonoscopy, meaning we remove that polyp. Okay, some of them that will be the definite treatment for that patient. Okay, but most of the patient stage 1 or stage 2 disease, stage 3 also most likely will need some kind of colon surgery.
Okay, got it. So, the last question we're going to ask before we go to break, from Gloria Jackson. If the family member has history of colon cancer, is it high chance for relatives to get the same cancer? This is also same as Mak Din punya question. Colon cancer ni boleh jadi penyakit keturunan ke? Yeah.
Okay. In colon cancer we have familial cancer, and we have there's increased risk of because of relative lah. Okay. Familial cancer is the less common type. Okay, but memang the whole family is at risk of getting colon cancer even at a young age. Okay, this one is the same thing yang I was telling about the familial adenomatosis polyposis (FAP). Okay, if a family member we got FAP, memang we will screen the whole family for FAP too. Okay, okay,
Okay.
but let's say this is not FAP. FAP differs a bit from the colon cancer because this patient have thousands and thousands of polyps. Okay, normal
Okay.
colon cancer, they usually we find a few only of polyps that turn out to be cancer. Okay, so this is a slightly different spectrum, but different disease. Okay, but yes, if let's say a first degree relative, a mother or father, okay, siblings, okay, your anak ada colon cancer, our own risk of colon cancer is a bit higher than the normal population. Okay, if second degree relative like your cousins, okay, your ni have colon cancer, the risk is just slightly higher, not as the same as a first degree relative. But yes, generally, if the family member has colon cancer, you are at a higher risk of getting colon cancer too.
Okay, got it. Okay, cool. Let's go. Thank you so much, Doc. We will continue with the Q&A, but first, let's get into the quiz, right? It is quiz time. As mentioned in the earlier part of the show, there are some drawstring bags up for grabs. All right, who wants to win it? Let me know in the comment section. But what do you need to do in order to win? First, you got to be sure to share this video out at least 3 times and remember to set the post to public. Okay, so that everybody can see it. Next, answer the next 3 questions that I'll be showing on the screen in a single comment, single line, and you are on the way to win prizes. So let me repeat that. Share this video out 3 kali and remember to set the post to public so everyone can see it. Secondly, answer the 3 questions that we're going to show on the screen in a single comment, and we will select the first 3 winners. We will select 3 winners based on the correct answers and shared posts. Okay, so are you ready? Let's take a look at the questions. Question number 1. Urinating is one of the functions of the colon and rectum. True or false? Urinating is one of the functions of the colon and rectum. True or false? Colon cancer is the most common cancer in Malaysia and the highest cause of death in Malaysia. True or false? Okay. Colon cancer, the most common cancer in Malaysia and the highest cause of cancer in Malaysia. True or false? The third question is colonoscopy and sigmoidoscopy are the only types of screening available for colon cancer. Colonoscopy and sigmoidoscopy are the only types of screening available for colon cancer. True or false? Let us know the correct answer. And while waiting to hear who our winners are, let's go back to our Q&A, okay? Going to Cecilia Chong. Okay, Doc. So Cecilia Chong punya soalan is it possible for someone to have colon cancer and have symptoms of gaining weight instead of losing weight? Very good question. Boleh ke, Doc?
Yeah, because some of the symptoms are not very specific, okay? But some of them also have underlying obesity. So sometimes the losing weight itself is not specifically for cancer, okay? But this is what we commonly see in cancer patients because the body, I mean, the cancer tends to use up the body reserve. That's why they lose weight. Okay, but yeah, the answer I would say is some patient can be gaining weight despite having cancer.
I see. Okay, got it. Okay, so this is, I think, a technical question from LKB Clinic Bintulu. Hi, Dr. Vesh here from LKB Clinic. What is the role of FOBT in initial preliminary testing for high-risk patients, those with suggestive symptoms? This is in view that sometimes fecal immunochemical tests, fecal DNA tests may not be accessible, especially those in the suburban outskirts setting. Okay, Doc, help. I tak faham soalan ni.
Okay, basically Dr. Vice is asking, okay, whether there's a role for FOBT because even the fecal immunochemical test, there's 2 types available. Okay, so for Dr. Vice, okay, if someone who is actually you would deem as a higher risk, meaning probably some family members or multiple family members with cancer, okay, and they have symptom, it is recommended to refer to a surgeon for colonoscopy terus. Okay, if you wait for screening because FOBT sometimes can turn out to be falsely negative, so you can delay the actual diagnosis. So in this condition, I would recommend Dr. Vice to refer directly to a surgeon for colonoscopy.
Okay, got it. Okay, cool. Going back to Mak Din's question, boleh sembuh ke colon cancer ni? Doc, I think we didn't touch much about rawatan. We talk about early detection, but I think a lot of people, when we hear cancer, it's usually a death sentence. And we've had enough episodes to know that it's not necessarily. So what can you share with us with respect to Mak Din's question, boleh sembuh ke colon cancer ni?
Okay, for Madin, yeah, okay, it's a good question. Okay, yeah, I also didn't touch much on that during my earlier talk. Okay, so actually with this advancement in medical technologies and our modern medicine, okay, colon cancer is actually treatable, especially in the early stage. When I say early stage, is usually stage 1 or 2, okay, and up to stage 3. Even if some stage 4 actually can we some can there's multiple treatment option for stage 4 disease. So this is not true, let's say 20, 30 years ago. If you have stage 4 disease, it's like a death sentence. Okay. But no, now almost up to stage 4 is potentially curable. So that's why the best is still to be diagnosed early when we do regular screening, diagnose the disease before the stage is at an advanced stage.
Okay. Right. So even stage 4 can be cured, yeah, doc?
Yeah, but yeah, I mean, in most medicine, everything is possible. Now the issue is just the cost of it.
The cost. Okay, got it. Okay.
Yeah.
Okay. Question from Cecilia. Can doing colonoscopy too often damage the colon? Good question, I think.
Oh, yeah. Okay. Okay. Thank you, Cecilia. Okay. Okay. There is risk involved in doing the colonoscopy. That's why we label it as an invasive test. Okay, because introducing something and a foreign object into the anus, of course there are risks involved. Okay, part of it is injuring the bowel. Okay, the worst part of it will be perforating the bowel and can cause infection into the abdomen and even death. Okay, this is not a common complication, but it is recorded lah. Okay, there are some it can happen. Okay, probably 1 in 1,000 procedures. Okay, so that's why we don't actually recommend colonoscopy too often. If let's say for screening, memang we only recommend if it's negative colonoscopy, you shouldn't probably you need to wait about 10 years to get your next colonoscopy. Okay, if let's say the first colonoscopy reveal a polyp, okay, and we already done a polypectomy, what we do is usually we repeat the colonoscopy in about 6 months to 1 year time. Okay, if the polyp doesn't recur again, usually we can still go back to that 5 to 10 year interval of colonoscopy. So I think this comes to the responsibility of the healthcare provider, but we tend not to promote doing a colonoscope too often. We usually try to justify how often we do the colonoscope.
Okay. I've got two more questions before we announce the winner. But in the meantime, I just noticed Yu Kyong said, Tanya, we haven't announced the winner yet. Yu Kyong sama. Okay. Second last question from Oko Pelia. Lovely name. Colon cancer ni boleh merebak ke tempat lain ke, doktor?
Okay, terima kasih Oko. Jadi ya, especially kita panggil kalau colon cancer yang dah spread ke tempat lain tu stage 4 disease lah. Okay, paling common punya tempat dia spread adalah hati, okay, paru-paru, tulang dan otak. Okay, kebiasaannya rawatan bila dah merebak tu lebih susah banding dengan stage awal. Jadi macam dari awal kita cakap memang saya recommend untuk buat pemeriksaan awal ataupun screening.
Okay, so datanglah screening ke Columbia Asia awal-awal, okay? All right. So next and final question dari Mary Hannah. Hi doctor, if one is always feeling bloated, is it also a symptom of colorectal cancer? My husband always drinking Malex or Eno every time he feels bloated. Thank you very much.
Okay, thank you for the question, Mary. Okay, so bloatedness is also a common symptom among our population. Okay, but usually it's more associated with upper GI, meaning the stomach part. Okay, but some patients do present as bloating or dyspepsia as a presentation of colon cancer. Okay, uh, in this situation, again, I would emphasize because it's a symptom that is not going away. I would recommend Mary Hannah to bring the husband for check-up to your preferred doctor lah. Okay, because without touching or examining the patient, we can't really give a proper risk assessment.
Okay, got it. Okay, cool. That comes to the end of the Q&A, and now it's time to announce the winners of the quiz. Now, before we announce the winners, let's take a look at the questions. So we can have the questions again, and let's see what the correct answers are, yeah? Okay, so soalan pertama, urinating is one of the functions of the colon and rectum. The answer is Doc.
It's definitely false.
Yes, because it's everything else except that. Colon cancer is the most common cancer in Malaysia and the highest cause of cancer death in Malaysia. True or false?
It is false. It is second highest cause of cancer death in Malaysia.
Awesome. And colonoscopy and sigmoidoscopy are the only types of screening available for colon cancer. The answer is
It's also false. There are a lot
yeah,
more
those are
tests that we can offer. Yeah.
yeah, especially the home tests, right? The non-invasive ones. All right. So thank you
Yeah.
very much. And the winners of the drawstring bags are Matt Dean, Annabelle Lam, and Key Take Wing. Congratulations. They are again Matt Dean,
Congrats,
Annabelle
everyone.
Lam, and Key Take Wing. Congratulations to all our winners. Okay, so basically, stay tuned. We're going to be sending you a message on Facebook Messenger, so please check your messages to find out how you're going to receive your prizes. All right. Thank you so much. Thank you so much, Doc, for today. We've definitely learned a lot. Very clear explanation from you. Thank you so much. Let's give Doc Khairil a round of applause, shall we, before we say goodbye? Yeah. Let us know how grateful you are in the comment section. Thank you, thank you, thank you. All right, so that's all the
Yeah, thank
time
you,
we have
Nina,
for
too,
today.
because yeah, thank you for giving me the opportunity to share what about my passion.
Yeah, your passion, right? Thank you so much. We can definitely see it. So thank you so much, Doc. That's all the time we have for today, ladies and gentlemen. We hope you learned a thing or two. I, for one, learned a lot. And if you know someone who's going to really appreciate today's information, the tips and insights from Doc Khairil, please share this video out. Tag them because you never know who it's going to make a difference to, and give us lots of likes and loves and hugs if you want, virtual hugs in the comment and in the emojis. Yeah. So thank you again. Till then, take care of each other, and we'll see you in the next episode of Doctors Go Live. Bye.
Yeah, bye, everyone.